Today is going to be great CME just dedicated on endometriosis. So when they were talking about the new molecule, and the second will be endometriosis in adolescents, then I thought, let me just give you insight about endometriosis with infertility. I have based this particular presentation on frequently asked questions. Because when the patient you need to counsel, they only ask, you don't have to only explain them. Now, the understanding endometriosis and its an impact on fertility is very important. Now, what is endometriosis and how does it affect fertility? Endometriosis is a chronic inflammatory condition. As far as endometriosis is concerned, you must always talk about it is chronic inflammation, and chronic inflammation. Where the endometrial-like tissue grows outside the tissue, causing pelvic pain and infertility. It affects fertility by distorting pelvic anatomy, inducing inflammation, impairing implantation, and reducing ovarian reserve. As far as endometriosis is concerned, it is said is a progressive disease, is a debilitating disease, pain, pain, pain. And it has no cure. What percentage of women with endometriosis experience infertility? Nearly 30 to 50% of women with endometriosis have infertility, making it one of the leading causes of female infertility. How does endometriosis cause implantation failure? It is the elevated inflammatory cytokinins, IL-16, TNF-alpha, and many others. Another factor is progesterone resistance, and oxidative stress disrupts the endometrial receptivity necessary for embryo implantation. Does the stage of endometriosis correlate with infertility severity? While the moderate to severe, that is stage 3 and 4, endometriosis more commonly affects fertility due to adhesions and ovarian cysts. Whenever you have a chocolate cyst, she's already in grade 3, stage 3. And even mild stage 1 and 2, it can impair implantation through biochemical alterations. Can deep infiltrating endometriosis affect fertility more severely? Yes. The deep infiltrative lesions in the rectovaginal septum, bowel, ureter can worsen pelvic adhesions. There's an extreme dyspareunia in such cases. They distort the reproductive organs and lead to higher implantation failure rate. Now, as for the diagnosis and the evaluation of endometriosis in an infertile woman is concerned, what is the gold standard for diagnosing endometriosis in infertility cases? Laparoscopy with histological confirmation remains the gold standard. But lately, the various guidelines, in spite of that this is a gold standard, suggest that diagnostic laparoscopy and operative laparoscopy should be kept to minimum. Transvaginal sonography with the kind of machine which are available, MRI are non-invasive alternatives to detect deep infiltrating and ovarian endometriosis. Is there a role for serum biomarkers in diagnosing endometriosis-related infertility? CA-125 has a limited specificity, but emerging biomarkers are microRNA, VEGF, and inflammatory cytokinins. I think in a coming future, you'll find many of these markers you'll be using it day in, day out. Though these are potential non-invasive tests for diagnosis. When should an infertile woman be screened for endometriosis? The screening is recommended for women with chronic pelvic pain, dysmenorrhea, dyspareunia, or unexplained infertility. Whenever such symptoms are there, you have to suspect that she may be having an underlying endometriosis. How does AMH testing help in endometriosis-related infertility? We all know that AMH levels are often lower in endometriosis due to ovarian inflammation and the surgical interventions, indicating a compromised ovarian reserve in such cases. What imaging modality is best for detecting endometriosis in infertility patients? Transvaginal sonography with Doppler is preferred modality for diagnosing ovarian endometriomas in good 85 to 90% cases with the sensitivity and specificity of the same duration. Management approaches, that is medical or surgical. Does medical treatment improve fertility in endometriosis? This is a very big question. Medical therapy, whether it's GnRH agonists, progestogens, OCPs, suppress disease progression and pain, but does not improve fertility outcomes. So it is not recommended for women actively trying to conceive. My another presentation is just based on 3-4 questions, and these questions are: medical treatment role for patient of infertility with an endometriosis when she comes to you with problem of infertility. It has no role. But the people who have a little knowledge about endometriosis have a knee-jerk reaction, and they give GnRH analog and Dynogest. It's a reflex. So one thing is, whenever she's coming for infertility, these medical treatment has no role. The second question is what is the place of surgery? Now, in a mild disease, which is stage 1 and 2, no surgery is advocated. If you do ovarian superovulation plus you do IUI, the chances of success are pretty high. And the consensus report or the evidence has not come in favor of surgery in mild disease, that is stage 1 and 2. As for the moderate disease is concerned, which is called moderate to severe disease, pain element is too much, and for that the surgery is required. And in this, you do a surgery and soon after suggest these patients IVF, because the first 6 months is the golden period for them to conceive after surgery. Now the third question is, you've done the surgery. Medical treatment role for patient of infertility with endometriosis who have just had surgery. No role. First 6 months should be remembered that they are golden period for having a pregnancy and should never be wasted by medical treatment. When is laparoscopic surgery indicated in endometriosis-related infertility? Laparoscopic excision and ablation. It's not, you do a laparoscopic surgery, drain and come out. That's no treatment. It has to be excision. Ablation is much more beneficial for stage 1 and 2 disease to improve conception rates, but should be very, very carefully considered. Good results are not proved. There is no evidence. In stage 3, 4, because of pain, you undergo surgery, but do not forget, ovarian reserve becomes less and less depending upon how many times you do the surgery for that patient. Does ovarian cystectomy for endometriomas improve fertility? Cystectomy can improve spontaneous pregnancy rate, but it reduces ovarian reserve. This part must be always remembered. The surgery is indicated for symptomatic endometriomas more than 4 centimeters or when distorting pelvic anatomy. Should endometriosis patients undergo IVF directly instead of surgery? For severe endometriosis or recurrent cases of IVF is often preferable, as surgery can further reduce ovarian reserve without significantly improving the pregnancy rate. What is the role of GnRH analog before IVF in endometriosis? 3 to 6 months of GnRH agonist therapy before IVF can improve implantation rates by reducing inflammation and improving endometrial receptivity. Now here, many IVF experts also get confused. In endometriosis, now everybody does 2-stage segmented IVF. In one, they make the embryos and keep, and second time they transfer. So if you find that the reserve of this patient is less, then pick up and make the embryos and freeze them. And then you give GnRH analog. You can give 2 injections, 3 injections, or even more injections. The more the injections you will give, the inflammatory process will come down and the pregnancy rate will jump up. Now, as for the assisted reproductive techniques in endometriosis associated infertility is concerned, what is the first line ART option for endometriosis patients? Superovulation with IUI is beneficial for mild endometriosis, that's stage 1 and 2, but IVF is preferred choice for moderate to severe disease, failed IUI, or tubal involvement. How does endometriosis impact IVF success rates? Lower oocyte yield, lower fertilization rates, poor embryo quality, lower implantation rates are commonly observed in endometriosis patients undergoing IVF. Should frozen embryo transfer be preferred over fresh cycles in endometriosis? Now the consensus is on FET. That is, yes, FET after downregulation with GnRH agonist improves pregnancy rates in endometriosis patients by reducing inflammatory cytokinins in the endometrium. Does adenomyosis affect IVF outcome in endometriosis patient? Yes. Endometriosis and adenomyosis go hand in hand. Coexisting adenomyosis worsens implantation rates and may require GnRH downregulation or uterine preparation before embryo transfer. Can oocyte freezing be considered in young women with endometriosis? Big yes. All your patients who are young who have an endometriosis, do counsel them कि समय रहते आपका अपना fertility preservation करा लो. Best time is around 30 years. So they must consider fertility preservation. Lifestyle and alternative approaches in endometriosis associated in infertility. Can diet impact fertility in endometriosis? These are new areas. An anti-inflammatory diet rich in omega-3 fatty acids, antioxidants, and low in red meat, dairy products may reduce symptoms and improve fertility. Is there any evidence supporting acupuncture or supplements for endometriosis-related infertility? Limited evidence supports acupuncture, and the supplements like vitamin D, curcumin, NAC, that is N-acetylcysteine, may have anti-inflammatory benefits and may require more research in this area before they are advocated. Does weight loss improve fertility outcome in endometriosis? Yes. Reducing BMI in overweight patient improves hormonal balance, reduces estrogen dominance, and enhances ART success. What is the impact of stress and mental health on endometriosis-related infertility? Chronic stress increases inflammatory cytokinins and worsens symptoms, making psychological support, yoga, mindfulness activity are important adjuvants as far as the therapy is concerned. Should all endometriosis patients with infertility consider fertility preservation? Big yes. Woman has endometriosis, which is a progressive disease. Ovarian endometriomas or planned surgery should be counseled about oocyte and embryo freezing. Long-term consideration and future prospects. Does pregnancy improve endometriosis symptoms? Till now we were thinking that yes, it does. एक बार pregnancy हो जाए तो symptoms disappear हो जाते हैं, पर ऐसा नहीं है. Pregnancy-induced hormonal changes, which is progesterone dominance, can temporarily suppress symptoms, but recurrence is common in postpartum patients. What is the recurrence rate of endometriosis after fertility treatment? Recurrence rate ranges from 20 to 50%. The gap can be there 20 years, and the gap can be there only for 2 months. So it all depends upon your things. It is seen 20 to 50% is recurrence within 5 years, emphasizing the need for long-term medical management post-conception. Are new medical treatment emerging for endometriosis-related infertility? The research is ongoing on the selective progesterone receptor modulators, immunomodulators, and stem cell therapy, but none are yet standard treatment, so the time you have to wait. Can endometriosis-associated infertility be completely cured? There is no definitive cure for endometriosis as such, but timely ART Optimal surgical decisions, lifestyle modification can significantly improve reproductive outcomes. What should be the key takeaways for gynecologists managing endometriosis? Infertility, early diagnosis, individualized management, fertility preservation counseling for younger people, multidisciplinary approach are crucial for optimizing outcomes. So, big thank you.